our patient will come in, we'll of course, or maybe we've been called by the monitor tech to say that the patient has some type of dysrhythmia. We would then, of course, check the patient. We're gonna go ahead and make sure we put our patients on the monitor, and we're gonna put the pads on. Most facilities now use pads. I mean, unless you, I guess at a very, very small hospital, some people still use paddles, but for the most part, most people use pads. And these pads are pretty much dummy proof because they have the little picture on there telling you where to place them. Now, don't get caught up in the fact that this one say go here and then this one says go here. It doesn't matter, just as long as you put them in the right place. We'll just kind of pull those off. We'll place the pad here and then place your other pad here, like so, okay? Once we do that, of course, then you want to make sure that you cut your monitor on. Most facilities, well, some use LifePak 9s. I think Baptist uses the Zoll monitors, and we tried to simulate and get a monitor as close as to what you would be using in your facilities. We put the patient on the monitor and see what rhythm. What rhythm is this patient in? Oh, I'll answer it one.
Okay, people that can see.
Normal.
People that can see, what is
Brady
it?
is
Is it 72?
Okay, so what is it?
Normal sinus.
Normal.
Is it really normal sinus
Oh.
rhythm?
Well,
Then we, at this point, we need to maybe check our patient, because if the patient does not have a pulse, then that would be maybe some pulseless
Pulseless
electrical
electrical
activity. Okay. So then, of course, we're gonna, whatever rhythm our patient is in, then that would determine the treatment that we gave our patient. What rhythm is this patient in?
V-fib.
V-fib. So what's gonna be our treatment?
defib.
Defibrillation. Okay. So when we defibrillate our patient, we need to make sure that we are on defibrillate when we defibrillate, because remember, and it was way back when, but we talked about defibrillation versus cardioversion. Because with cardioversion, it's a synchronized shock, but of course defibrillation is not a synchronized shock. Of course, with defibrillation, you're going to use higher joules with defibrillation versus cardioversion. Okay, so we're going to, for the sake of this code here and whoever our physician will be, we're going to go ahead and defibrillate, and of course it's on the defibrillator mode. Okay, want to make sure when we get ready to defibrillate our patient, first of all, now we have 200 joules that is selected. Okay, so then we have to charge this monitor. Okay, want to go ahead and charge. Okay, it is ready to shock now. Next thing we need to do, we need to shock the patient, but we need to make sure that we're watching the environment around, because you got a respiratory therapist who is bagging the patient and may think that they're off the bed. I have a lab coat on. I may be kind of leaning over. So make sure when you get ready to shock your patient, you stay all clear, but not only stay all clear, but physically take a survey to see that the area is clear. Okay, once the shock has been advised and everybody's all clear, then we're gonna shock our patient, okay? Hopefully, when we shock our patient, our rhythm will convert to something like this, which is, the people up front,
Normal sinus.
that is a normal sinus rhythm. That's textbook what we want to happen. Not all the time does that happen. What else? We do not, we'll do about 5 cycles, and then of course we want to then check our patient with the new CPR guidelines and ACLS guidelines. You don't want to waste a whole lot of time checking your patient's pulses, because the thought is if the patient does have a pulse, they will let you know. They're going to start having some type of movement or something. So you don't want to waste a whole lot of time checking to see if the patient has a pulse, okay? In your CPR guidelines, you were taught, of course, you're going to do your chest compressions, and then we would do our 2 breaths, okay? If your patient, if we're in a hospital setting and your patient has an advanced airway in place, an ET tube, remember you all talked about that, that was on your last test, your ET tube? Your patient should have an advanced airway in place. And if your patient has an advanced airway in place, we don't stop with the breaths. You're going to continue to give your patient a breath, and you're going to give them about every 6 to 8 seconds. Okay, just gently squeezing. Okay, you don't want to hyperventilate the patient, but gently squeezing. That's if the patient has an advanced airway in place, okay? When we're doing chest compressions, did you go over chest compressions yet? No. Okay. When we do our chest compressions is not the time to be cute, okay? I'm cute. I can do mine. I'm cute. I can do mine. No, but actually, you are not. It's not the time to get cute. First of all, you want to bring the bed to whatever level is appropriate for you. Okay. If you are a little short, you may have to get a stool, and there are stools upstairs in the simulation room. Thing you want to do is you want to make sure that you are in the correct place. If you need to pull your gown down, typically you're going to be in between your nipples. Okay, now if you're a lady and their nipples are down a little further than they're supposed to be, you don't want to be in between their nipples. You want to kind of go up and go to the appropriate place. Okay? Make sure what I do is I always lock my hands. Okay, and you know, sometimes you will kind of like lean these fingers over. So one good thing, you can kind of fold your fingers in, or you can raise them up, because you don't want those fingers kind of laying down, because that's how ribs get broken. Okay, think about it. This is a nice sized man here. We have to compress his heart. Okay, so we need to make sure that our chest compressions are effective. Okay, so in doing that, you need to make sure we go down. And if you actually effectively do chest compressions, after a cycle, you're going to probably be tired if you're doing them right. Now, if you just kind of, you know, bending your arm, you see the difference in it? I'm not tired. But if I truly block my arms out and do the compressions, okay, trying to get 100 in a minute, that's quite a bit. That's a workout. Okay, so you need to make sure that you're compressing. A lot of facilities now are using thumpers or Lucas devices, and they actually provide the chest compressions. But for those that don't, you have to do them, manually do those chest compressions, okay? When you are checking for a pulse, when it is time for a pulse check, we never, ever check. You know, I mean, sometimes you may see people do this, but they should not. You should always check a carotid, okay? When you're checking a carotid, you don't want to check, you don't want two people checking at one time. You only check one, okay? One side. Your patient here has a line. We're going to use this as our line, and this is where we will push our medications from. And I guess that's it.
The main thing that we see is that people are real worried about cleaning the site and stuff. And while that is important when people are dying, I mean, you know, sometimes you just gotta, the issue is fast. And we see people do compressions over the stomach and all that, and then they do their arms like this.
We see your underwear.
Yeah. Yeah, please don't wear any thongs. Don't afford that. Yeah.
Yeah,
Please make sure you wear a t-shirt.
appropriate
Because your shirt, I'm
undergarment.
telling y'all, your shirt starts riding up in there and we start seeing all kinds of stuff. So, just wear a
And
t-shirt.
wear underwear.
Yeah.
Please wear underwear.
Wow. We see a lot. Men, we don't want to see your heart boxers and all that, so.
We only see a Trump stamp.
Spring break.
So what else?
Yeah. So please, and actually we're right behind you, and believe me, we're not just saying that to be saying
I mean,
it. We're
seriously,
saying that because
yeah.
for a reason. So make sure that you wear the appropriate things. And a lot of times, like she said, especially, I mean, I'm kind of well endowed back here, so I know a lot of times my shirts will raise up. So make sure if you need to put a t-shirt under there to kind of pull it, or you may need to do that as
Just
well.
stand in the mirror and do this, and if you see anything, then you need to wear
I
something
didn't
under
get
it.
it.
Okay.
Now, I know you're going to be nervous and it's real, you know, kind of hyped up, but this is a great learning tool because, you know, when you get out, you're going to be participating in this. And really, ACLS is entry level, really nursing. Everybody's pretty much going to be expected to learn, you know, ACLS. So this is a great time for you to get ahead of the game a little bit and kind of know how to do things, okay?
Also, make sure that you practice with these medications. I'm not sure I was out, but make sure you practice with those medications, because if you don't practice, we know you don't practice. Because the thing about it is, when you get into your code, you'll start fumbling with those meds, and you know, and you know, you open the box, and it's simple things, just like this box says open from this end. This is actually the end you need to open the box from, because if you don't, the medication is assembled so that, you know, when you open the box, you can pull the things out, and then of course you already went over that. Open it, okay.
Yeah.
So removing all of the yellow pieces and then screwing, you know. So
So-
make sure you have to actually physically do it though, in
So-
order to
So
understand
what'll
it.
happen is you'll come in and we're gonna rotate you through each station. So if you only have 3 people in your group, we might pull somebody from another group just to be your recorder, and you'll rotate through bagging. Did you talk about the EC and how to hold the bag? Somebody will bag, they'll chest compress, and you'll go through all 3 stations of medication. So we'll rotate you through each station until everybody has participated in that station to get everybody in, okay? So we're just gonna keep, and if it takes you 5 minutes to draw the amiodarone, we're just gonna keep waiting, okay? So be sure that you come up here and look and you familiarize yourself with what dose you might need to draw up and things like that, okay? Because amiodarone, we usually start with a higher dose and then the next second dose we go down, okay?
Okay, so if you're gonna bag your patient, you wanna make sure you hold your bag like so. I guess for somebody who's left-handed, you'll hold it like so, okay? Then you wanna make sure that this top part goes over your bridge of your nose. You wanna make sure that you get a good seal. So you see how I take my hand here and just kind of press down and I got a seal. And you can actually take your fingers and kind of cup that, okay? Because otherwise, if you just lay it here and just kind of half lay it or lay it the wrong way, the patient is not getting adequate oxygenation. So you want to make sure that you get a good seal, and then of course, then you bag your patient, okay? This is very comfortable doing. But again, you still need to maybe kind of mess around with the mannequin, play around, and just kind of hold this, because if you hadn't done it, it is a little awkward to you, okay? So make sure you hold, and then just get your seal and bag your patient, okay? Okay, so now we're gonna simulate this code.
You want me to do meds?
Yeah, we can do meds. Okay. Y'all ready? Okay, this is meds. Okay. Whatever y'all wanna do. Okay. Okay. So we're all working in same day surgery. And we got our patient back. Our patient came back from surgery, and the patient was doing fine. Patient was doing fine. You know, we don't anticipate any issues, and we're just rolling along. Patient, you know, just in normal sinus rhythm, and all of a sudden, our patient just converts on us. And our patient converts. So what is this patient converted to?
VTAC.
VTAC. Okay, so come on, what we're gonna do for VTAC?
All right, call a code.
Okay, so our patient, we're calling a code. Our patient does not have a pulse.
Are you
Because, okay,
Okay, call a code.
okay, go ahead.
Right.
Okay, all right, your code team arrived.
Okay, we got everybody here.
Have we given any meds?
Okay, I'll do meds. Do you anticipate any medication?
Yes,
that
go
you need?
ahead and give me some epinephrine. I want 1 milligram of epinephrine.
Let me know when you're ready for the epi.
Another breath.
Now, had this patient had an advanced airway in place, we would continue bagging the patient. But since we don't, we just got here, the patient does not have an ET tube in place, so she's gonna do compressions, 30 compressions, and then we're gonna do 2 breaths. Okay? We ready for meds?
Okay.
You have the
I do. I
epinephrine?
have the
Okay.
epi, all right.
Go ahead and give the epi.
Epi's in, followed by a 10 cc flush.
Okay. Kind of looking at the monitor. Okay, we still got that going on.
What other medication do you think you might need?
Maybe give me about 300 milligrams of amiodarone.
Breaths. Can you switch? Yeah, switch.
Always check your person who's working with you. You're gonna monitor them for fatigue, because if they are too fatigued, they're not gonna give effective chest compression. Okay? Recorder, can you please let us know when it's time to give some more epinephrine?
I will. We got 2 minutes.
Okay. She said we have 2 minutes. The epinephrine can be given every 3 to 5 minutes. Let me know when you have the amiodarone
I have
ready.
amiodarone ready.
Okay, I'm ready for you to give the amiodarone.
Alright, amiodarone in, followed by 10 cc flush.
You notice that it was very important for her to let us know when the medication was in. Number 1, for the recorder, so that they can document. Go ahead and give me another milligram of epinephrine. I anticipate us having to give that.
Epi's ready when you're ready.
Okay, the epi's ready, but I noticed that our patient has had a change on the monitor. Okay, so I'm gonna go ahead and charge because it looks like this patient is in V-fib. When the patient's in V-fib, I know that the patient does not have a pulse with V-fib. So I'm gonna go ahead, we're gonna go ahead and get the pads on our patient. Okay, I'm gonna go ahead and charge.
Okay, everybody clear?
I'm clear, you're clear, we're all clear.
We're gonna shock at 200. We're all clear. Okay. Go ahead and resume compression. Let me know when
Time
it's
for epi.
time for epi. Let's go ahead and give that other dose of epi.
1 milligram of EpiM followed by a flush.
Okay. We're gonna let her circulate that medicine because it does no good to give medication and it's not circulating. That's the purpose of your chest compressions, to circulate your meds. Okay. We're circulating those meds. We're circulating. And so now we have had a rhythm change, another rhythm change. So, hold compression.
We have a pulse.
Okay, we have a pulse. We are wonderful nurses.
And
We
is
have lots of
he
patients.
breathing?
Is he breathing?
We'll say he
Yes,
is.
I see his chest rising and falling.
You
Okay?
killed me.
So we saved our patient. Okay?
Sinus rhythm.
It's sinus rhythm. Okay, so we're gonna go ahead and transfer this patient to the intensive care unit. Okay? One thing about it, number one, I said making sure when we do chest compressions that there are effective chest compressions after you give medications, that we do chest compressions because that's what circulates your drug. Okay? Also, when I did do a pulse check, we wanted to make sure that they were not doing chest compressions when we did a pulse check. Because if you are doing an effective chest compression, you should feel a pulse because that's the purpose of your chest compressions. So you want to hold compressions to check and see if your patient has a pulse. Okay? So ladies, you all did a fabulous job. Are you tired? Okay?
I have a question.
Yes.
Let's say, for example, the monitor was right to a normal sinus rhythm, and they
Mhm.
already had a pulse, and then y'all asked, is the patient breathing? And y'all said yes. If the patient had not been breathing, would you just keep doing the ambu bag?
We would
or
do
also
rescue breaths. If they had a pulse, there is no need to do the chest
the
compression.
compression? Okay. So just keep bagging them for
We'll keep
how-
bagging, just kind of do some rescue breaths, and then maybe until the physician comes so that he can intubate the patient because maybe there is some respiratory issue going on. But if they have a pulse, you most definitely do not want to do chest compressions because the heart is already beating.
How many times?
You're gonna do breaths 8 to 10 seconds, every 8 to 10 seconds, because you don't want to hyperventilate your patient. So about every 8 to 10 seconds. Okay. And some ambu bags, some of the newer ambu bags, they have a little light on them, and it kind of lets you know when to do your breath, when to ambu the patient. But again, about every 8 to 10 seconds. Also, you need to be familiar with what you need to do. I've been in several codes with physicians that either are new or are old. And they'll tell you to do something in the middle of a code and you looking like, it's not right. So, you kind of need to be familiar. Just kind of like how, when you use S-bar, and when you use S-bar, you have an R is for your recommendation. Sometimes you kind of anticipating what the physician, and sometimes you just have to, and there's new nurses, I know that's difficult. But, sometimes they may call out something, or maybe they're just not thinking and be like, sure, doc, you sure you want to do that? Or maybe say, for instance, we got a patient who's tachycardic and he calls for some atropine. He's like, nah, let's do something else, So you need to be familiar with what's going on in order to know what you need to do. Okay? Again, make sure that you practice with those meds, because I promise you, we will laugh at you. But honestly, you already nervous about the situation, and so you'll get those meds and kind of fumble around with those meds. So again, you do need to practice with those meds to become familiar with them. Are there any other questions? I know y'all should have some questions.
We don't expect perfection, but we do expect you to be prepared,
Yes, we do.
okay? And then it's a learning experience because you're kind of still learning, but we do expect you to come prepared and at least be familiar with the algorithms, know what doses, et cetera, the drugs should be drawn up.
Is that
Yes.
posted?
Yes, it is.
It's yes, so that means you can do.
And I know you do compressions and you do it until the co-team gets there. Once the co-team is there, what's your responsibility?
That is determined by how many people come. If they need you to record, then you become the recorder. If they have enough people, that's really kind of up to that situation in the facility where
But
you're
don't
at.
leave the room.
Yeah.
Don't leave. Because I've been to some codes, because
Yeah.
I work ICU and we answer codes. And you get to the room and the doctor get there and you trying to figure out, well, okay, who is this and
Yeah.
why are we here? And the nurse has just
She
left.
down the hall giving her other meds.
And I'm like, nah, that's not acceptable.
And you actually, like where I work at, we do our own code, so, you know, you need to definitely be familiar. It just depends on the facility you work at.
And the thing about it is, no matter how much practice you get, no matter how long you've been working, I've been working critical care, and I promise you, every code, I still have an adrenaline rush. Because number one, it's because this is somebody's life. That, you know, this person could live or die, and it could be based on what I did or did not do. So there's always some level of anxiety. I have mild anxiety. And that's normal. That's what motivates you. That's what keeps you alert. But you should have that. But to the point where you dropping meds and fumbling and doing all that now, we got a problem. But, you know, you should have some anxiety.
Now at LeBonner, a code team comes and they completely take over. They have people that come and they know their roles. The person from special care is the chart person. The person from ICU brings the meds. So it just kind of depends on where you work.
Okay. Any other questions?
Yes. Yes. He just does it. And let me just tell you, we'll know Friday when we come in, we may have to use iStand. One of the mannequins is not working. So, but if we do, we'll give you a little orientation to iStand. But yes, in SIM, you actually push. Okay?
And you actually do those chest compressions.
You can
And
chest
y'all,
compress.
spaghetti arm, I see spaghetti arms so often where your arms are not locked. Lock those arms and get over the top of him and push down. That's the best way to do it.
And if you're tired, say, I'm tired, I need to switch. Okay? Before the code person switches you. If you're worn out, say, I need to switch. Okay? And if you are bagging and you see the person fatiguing, say, do you need to swap? You know, because you will be tired and your back will be sore and stuff the next day if you're doing them properly. Okay?
Okay.
All right. What time is it?
Hold on, let me tell you my new watch.
Oh,
Oh, 32.
Okay. I have